Managing complications during stent delivery and implantation. The complex nature of the procedure predisposes to unique complications and technical challenges. Complications of stenting implantation can be broken into several major categories. Delivery failure. Failure to deliver the stent is most often due to 1. Suboptimal guide catheter support. 2. Failure to predilate a significant coronary lesion. 3. Unsuspected proximal tortuosity or calcification of the vessel with unanticipated vessel rigidity and acute angulation. 4. Unsuspected obstruction proximal to the target lesion. 5. Failure of adequate guide wire support. For these reasons, predilatation has advantages for stent delivery in most circumstances. A pre-deployment balloon that tracks easily to the lesion, dilates the lesions simply, provides evidence of good guide catheter support, and bodes well for the delivery of stent to the lesion. On the other hand, difficulties with advancing the balloon, guide catheter instability, and difficulty in dilating through tortuous segments herald the onset of stent delivery problems. Initial results shown in the left side and further dilatation which has caused distal plaque fracture as shown in the figure. In arteries that are highly tortuous and have multiple bands and folds, guide wire selection is an important factor in stent delivery success. Extra support guide wires may not be ideal for initially crossing lesions, producing folds and pseudostenosis, and conventional guide wires that are softer may permit delivery of the stent system without encountering the pseudostenosis.
Technical manipulations when a stent fails to advance. General. Best technical manipulation. Secure a more stable guide position or, if possible, the guide can be deep-seated safely. A potential late complication is osteostenosis due to endothelial trauma. Constant forward pressure is exerted on the stent catheter while pulling the wire back to decrease friction inside the stent catheter lumen and to straighten the stent catheter. Additional proximal segment dilation or plaque removal facilitates stent advancement. Wire manipulations. Advance a second stiffer wire to straighten the artery, the buddy wire. Technique. This stiff wire can cause wire base. Advance the stent on the second stiffer buddy wire. Occasionally stents may advance more easily over a softer wire. Shape the wire along the curve of the artery to lessen wire base so there is less friction or resistance at the outer curve of the vessel in the path of the wire is more coaxial with the path of the vessel. Use a wiggle wire. Stent manipulations. If the problem is due to tortuosity of the proximal segment, change the stent to a shorter one. Select a different type of stent with better flexibility. Gently bend the stent to conform it along the curve of the artery. Guide manipulations. Change to a guide with a different curve to achieve better backup. And more coaxial to allow less friction at the ostium. Use a larger or smaller guide to achieve better backup. Techniques facilitating recrossing of a stented area by a balloon or another stent. General. Best technical manipulation. Steer the wire into a different direction or to a different branch to lessen wire base and increase more wire centering. Rotate the balloon catheter while advancing it and let the catheter enter the stent by itself through its rotational energy, like torquing the Judkins right catheter. Good wire manipulations. Bend the wire and place the bent segment near the ostium of the stent to be crossed to position the wire more at the center of the entrance of the stented segment and to decrease wire base. Insert a second stiffer wire to straighten the vessel. Change the current wire to a stiffer one. Balloon stent manipulations. Use a shorter balloon or stent. Use a more flexible balloon or stent. Use a fixed wire balloon to cross the stent. Use a fixed wire balloon to track alongside a buddy wire. Mount a stent on a balloon with the tip partially inflated. If only the balloon needs to enter the stented segment, inflate the balloon with 1 to 2 and so the balloon centers the wire in the lumen and facilitates the crossing of the wire and balloon.
Expansion failure, a persistent stent narrowing. The inability to fully expand the stent or have an appearance of narrowing after implantation may be due to 1. Tissue prolapse, 2. Cell sites, 2. Calcification or rigid vessels, 3. Dissection at stent margins, 4. Unsuspected thrombus formation within or adjacent to the stent, which may appear as narrowings related to stent implantation. During the balloon inflation phase of stent implantation, full expansion of the balloon should always be observed. If an indentation persists, higher bone inflation pressures, or a larger bone should be used. Failure of full stent expansion is usually the result of an inadequate predilatation approach. In cases where stent deployment appears suboptimal, thus imaging will confirm the mechanism of persistent narrowing due to tissue prolapse, complete apposition, heavy calcification, or in some cases thrombus.
Loss of access to the stent. 1. Loss of guide wire access to a stent may result in a complication, especially if the stent has been inadequately expanded or when new lesions have been produced distal or proximal to the implanted stent. Recrossing a recently deployed stent is facilitated by using a soft guide wire with an exaggerated tip loop to prolapse through the stent. Care should always be taken so that the wire does not enter under a stent strut between the strut and the arterial wall. Once the guide wire has crossed the stent, a sec-on problem may be encountered of inability to advance a balloon for high-pressure post-stent deployment. 2. Recrossing stents with balloons may be difficult when the proximal border of the stent is on a tortuous vessel segment, forcing the tip of the dilatation balloon into the vessel wall, where it is blocked by the stent struts. Several approaches can be used to overcome this problem. The guide catheter can be repositioned in a more coaxial manner. A stiffer guide wire can be advanced to reshape the curve of the artery. The balloon can be withdrawn slightly, rotated, and re-advanced. In inspiration or coughing, the balloon's profile should be as low as possible. Several operators have recommended putting a curve onto a stiff part of the guide wire and using it to advance across a tortuous segment proximal to a stent, and placing a curve on the balloon by forming it with the finger and using a technique similar to that of putting a gentle curve on a guide wire. Table 1-8 summarizes several technical manipulations that may be used to recross a deployed stent. Table 1-5 lists unique guide wire tip shapes that will help in difficult PCI situations. How to deal with malpositioned or embolized stent. Several techniques for recovery of embolized stents have been proposed. These include loop snares, basket retrieval devices, biliary forceps, biopsy forceps, and other specifically designed retrieval systems. Artery perforation. Consider using a covered stent. If stent-related dissection, thrombosis, and ischemia, then consider the factors are associated with an increased risk of stent thrombosis and ischemia. 1. Inadequate stent expansion. 2. Dissection, not covered by the stent. 3. Poor distal runoff or infarct in related vessel. 4. Presence of thrombus. 5. Subtherapeutic anticoagulation. 6. Vessels less than 2.5 mm in diameter. Subacute thrombotic occlusion is rare within the first week after implantation, but may happen during the week following discharge if the patient is not faithfully taking the prescribed dual antiplatelet therapy. Risk factors for subacute occlusion are previously noted. The risk of subacute thrombosis is increased when multiple overlapping stents are used. Subacute occlusion is treated with repeat balloon dilatations and continuation antiplatelet agents. The issue of ruptured or tethered balloon. Loss of inflation pressure during expansion of the stent can indicate balloon perforation. A ruptured balloon must be exchanged for a new one. If balloon rupture occurs after the ends of the stent are flared and anchored in the artery wall, the balloon can be deflated, rotated 2 or 3 times inside the stent, and gently pulled back inside the sheath and removed. A new balloon catheter is introduced through the sheath and positioned inside the partially expanded stent. Inflation of the new balloon catheter then completes the expansion and deployment of the stent. Alternatively, a rapid high-pressure inflation can deploy the partially opened balloon stent enough to fully expand the stent and withdraw the balloon. A tethered balloon may be caught on the edge of the stent. The ends of the stent may not have been expanded and anchored securely in the arterial wall. The balloon should be deflated, advanced slightly to the stent edge, rotated, and gently withdrawn. Safety of magnetic resonance imaging. After stent implantation, a magnetic resonance imaging (MRI) scan should not be performed until the implanted stent has begun to be endothelialized greater than 4 weeks. The risk of migration of the stent under a strong magnetic field is small, given the implant method. The stent may cause artifacts in MRI scans because of distortion of the magnetic field. In some patients this is not an issue because many stents may be non-ferromagnetic. Stent implantation before non-cardiac surgery. Catastrophic outcomes have been reported for stenting after non-cardiac surgery. Galuza et al. Noted that patients who underwent coronary stent placement less than 6 weeks before non-cardiac surgery, requiring general anesthesia, had a high incidence of myocardial infarction, bleeding, and death. Among 40 consecutive patients, there were 7 myocardial infarctions, 11 major bleeding episodes, and 8 deaths. 4 patients died after undergoing surgery 1 day after stenting. Stent thrombosis accounted for most of the fatal events, with the time between stenting and surgery as the main determinant of the outcome. It is recommended that elective non-cardiac surgery be postponed for 2 to 4 weeks after coronary stenting, which should permit completion of mandatory antiplatelet regimen and start of endothelialization, reducing the risk of stent thrombosis and bleeding complications.